Dear colleagues, welcome to today's EHRA webinar on lessons from the ReCircuit trial, when to choose direct oral anticoagulation or warfarin for atrial fibrillation, and how to handle these patients. My name is Jan Steffel from the University Hospital of Zurich. The aim of this webinar is to give you a better understanding of the use and management of vitamin K antagonists, as well as the novel or direct oral anticoagulants in the setting of AF ablation. Now, the cases today will be presented by two renowned experts in the field, Professor Stefan Hohenloser from Frankfurt and Professor Riccardo Cappato from Milan in Italy. Thank you very much for joining us today.
Thank you.
At the end of this 60-minute live event, you will be able to better know the available evidence regarding the management of NOACs in the setting of AF ablation, and you'll also know important pointers and aspects regarding anticoagulation in patients undergoing AF ablation for your daily clinical practice. Now, this session is supposed to be highly interactive, so we strongly encourage you to actively participate by sending in your questions, your comments at any time during the webinar through the chat. We'll have them on our iPad here and we'll ask them and discuss them as we move along. Anything you need to know, just ask. We'll provide tips and tricks for your daily clinical practice. This webinar is possible thanks to an educational grant from Boehringer Ingelheim. Before we start with the webinar, these are my personal disclosures right here. And with that, I will hand over to Professor Hohenloser. We're looking forward to your presentation.
Thank you very much, Jan. It's a pleasure to be part of this webinar. So good evening, everybody. I was asked to show a few slides on the content regarding the history of atrial fibrillation ablation and how to protect patients both from ischemic events and from bleeding events. You can see my conflicts of interest are shown here. So if we go back a little bit in time, it's probably fair to say that the therapy of catheter ablation was introduced in the 1980s, and it took a few years until the first interventional therapy of atrial fibrillation, I should say, was introduced, which was a surgical treatment at that time and was composed of the Cox-Maze procedure. A few years later, Michel Hassaguer was amongst the first to introduce the principle of catheter ablation of atrial fibrillation by mainly mimicking the Cox-Maze procedure. And then over the last 20 years or so, we have envisioned incremental improvements in the techniques of catheter ablation of atrial fibrillation, and it's probably fair to say that the mainstay of today's atrial fibrillation ablation is pulmonary vein isolation, and we have seen refinements in all sorts which make this procedure today no longer an experimental procedure but a well-established treatment for patients with symptomatic atrial fibrillation. Well, there have been a tremendous shift of opinions regarding how to protect patients from, as I said, ischemic events and bleeding events during the atrial fibrillation ablation. If we look in the past, guidelines and consensus statements such as this one in the year 2007 strongly recommended bridging, that is, stopping VKA therapy before the atrial fibrillation ablation, transitioning patients to mostly low molecular weight heparin, and after the procedure resuming vitamin K antagonist therapy. This was true until the expert consensus statement of the Heart Rhythm Society and EHRA in the year 2012. For the last 3 or 4 years, we have seen a tremendous shift in this, basically a shift of 180 degrees. And nowadays, guidelines and consensus statements do no longer recommend bridging because we have learned, and Riccardo is going to elaborate on this, that bridging is associated particularly with an increase in bleeding events, but also perhaps with an increase in ischemic events. So nowadays, the recommendations from all societies are to perform atrial fibrillation ablation on uninterrupted therapy with all anticoagulants. Anticoagulation before, during, and after the ablation procedure must be carefully managed to minimize stroke and bleeding risk. and the stimulus for thromboembolism differs before, during, and after ablation. By this I mean, for instance, if you look before ablation, introduction and manipulation of catheters may dislodge pre-existing thrombi. Therefore, anticoagulation is required ahead of time and prior to the ablation procedure to minimize the risk for left atrial thrombus formation. Well, during the ablation procedure, endothelial injury is induced by passage of sheath and catheters into the left atrium and by application of the ablation energy. Hypercoagulability triggered by contact of blood with the ablation instruments will further enhance the likelihood of thrombi and therefore of ischemic complications. After ablation, atrial tissue remains stunned for several weeks after the procedure, with a resultant decrease in contractility, and this, as well as endothelium, which was injured by ablation and needs time to heal, will increase the likelihood of thromboemboli as well. And it is with this context that we have to discuss how to best protect patients from ischemic events and at the same time for major bleeding events. And by that, I guess I hand over to Professor Carpato for the next few slides.
Exactly. Thank you very much, Stefan. Indeed, this is highly interesting. I mean, every once in a while we do see this in medicine, right? That there's the one train of thinking, and then all of a sudden we have evidence accumulating, and as you're saying, we turn by 180 degrees and do the opposite. We all promoted bridging, and now we all promote continued anticoagulation. So, Ricardo, please enlighten us. What were the evidence? What were the trials that led us to do so?
Thank you, Jan. Thank you, Stefan, for the nice introduction. It's also a pleasure for me to be here today. And we all together are actually looking forward to receiving your inputs in the discussion phase of our webinar. So my presentation deals with the general practice of periprocedural anticoagulation. And now these are my disclosures for your appreciation. And the topics that I would like to cover are summarized in this slide. First, why anticoagulation therapy in patients undergoing AF ablation. Second, which anticoagulation strategy. Third, do novel oral anticoagulants favorably compete with standard of care VKA in the periprocedural phase of AF ablation. And fourth, which studies were testing novel oral anticoagulants prior to the recircuit, which will be the focus of Professor Onloser's final presentation. Why anticoagulation therapy in patients undergoing atrial fibrillation? Well, the theoretical elements that Professor Onloser has touched in his presentation were confirmed as data were accumulating in large number of patients undergoing catheter ablation. And this is a study that I had the privilege to chair, and that was summarizing the complication rates and the description in about 16,000 patients undergoing catheter ablation worldwide. Stroke and transient ischemic attack accounted for about 1% rate in the entire population, not a trivial one. Fortunately enough, 1/3 of this complication was due to a permanent stroke, whereas 2/3 of these complications were due to transient ischemic attack. At that time, data were accumulating with all patients undergoing the interrupted warfarin strategy, which implied bridging with low molecular weight heparin being administered during the 2 to 4 days before ablation, and then with vitamin K antagonists being started immediately after the procedure, and low molecular weight heparin bridging be continued until the INR would range within the normal levels. Which anticoagulation strategy should we be using? It was in the year 2010 that a pivotal study named COMPARE was published, in which the traditional interrupted warfarin strategy was compared with an uninterrupted warfarin strategy. The study was enrolling 1,584 patients who were randomized 1-to-1 to continuous versus interrupted warfarin. And the data outcomes showed a relative risk reduction in patients being assigned to continuous warfarin of minus 90% in the incidence of stroke or TIA, minus 80% in the incidence of minor bleeding, and about minus 50% in the incidence of major bleeding. Now, this study was early adopted by a vast number of centers across the world, essentially because of the dramatic benefit that was shown, both in terms of efficacy and safety. But in order to put this study into a wider perspective, we should recognize, first of all, that the comparator arm, which was interrupted warfarin, was associated with an observed thromboembolic event rate of about 5%, which, as you may appreciate, is at least fivefold higher than the one that was going to be expected according to the data collected in the literature in much larger and more heterogeneous patient populations. Clearly, this unexpectedly high rate raises some concern about the extrapolability of this data into a more general model. And another important limitation of the study was that there was no predetermined working hypothesis driving the sample size. Now, 1,584 patients would not represent the usual model in which you would like a non-inferiority trial to be conducted if a new strategy like the continuous one was to be compared with the previous one, particularly when the expected rate of the primary outcome event in the control arm is in the range of 1%.
Now, Ricardo, while you're showing this, there's one question here from our audience, just to get everybody on the same page here, because there's a vast variety of people watching, some of whom have been performing these ablations for years, others may have just started or are in the process of starting. Just briefly, the target INR prior to ablation and after ablation. What's the target range that these studies, and also your study, also the ReCircuit study, what's the target range they're aiming for?
Well, if we apply an uninterrupted warfarin strategy, we should simply comply with the current standards of INR range. Mm-hmm. Nothing will change. It's easy also to remember. Mm-hmm. So lower limit 2, upper limit 3. This is for chronic treatment, and this should be maintained even in the periprocedural phase, and patients should be undergoing ablation if the INR value collected during the 3 weeks prior to the procedure are consecutively and repeatedly under this range, within this range. If that is not the case, at least 3 consecutive weekly taken sample size should be within that level.
Thank you for that question. Again, please keep putting in your questions. We'll try and answer as many as possible during the webinar. And also, even if we don't manage to answer them all, we will answer them during the following days offline so that you can read them up.
So, despite the limitations, the study was innovative, provided some relevant interest in this direction, and as a matter of fact was adopted by a vast majority of centers, up to the point, as you have heard in the introduction by Professor Onloza now, the uninterrupted warfarin tends to be the preferred and most frequently recommended strategy in patients undergoing AF ablation. The next question is, do novel oral anticoagulants favorably compete with the standard of care VKA in the periprocedural phase of AF ablation? In this meta-analysis provided by Nairus and co-workers very recently, a number of studies in which data were available for both patients receiving novel oral anticoagulants or vitamin K antagonists in their collectives are pulled together, totaling about 800 patients in each of the 2 arms. Please appreciate that most of these data do rely on historical controls and retrospective analysis. There is only one study, the first one, in which a prospective randomized comparison is made available. If we focus on stroke and TIA as a primary outcome event, there were essentially no differences in patients receiving novel oral anticoagulants versus VKA. Major bleeding, same outcome. Please appreciate that the strategy used for novel anticoagulants was quite variable in the different studies. In some studies uninterrupted, in some studies interrupted according to different protocols. So it's even difficult to combine and pool the data together for NOACs as a unified family. For vitamin K antagonists, they were mostly uninterrupted. For all bleeding, same similar outcome. And quite interesting also minor bleeding, similar outcome. Overall, this data encourage the understanding that novel anticoagulants administration in the periprocedural phase of patients undergoing AF ablation is associated with a similarly low incidence of primary efficacy and safety outcome events as in the standards of care vitamin K group. An interesting subgroup analysis was made in regard with cardiac tamponade, also showing in aggregate that receiving novel anticoagulants did not expose this patient population to an excess risk of cardiac tamponade. Final question, which studies were testing novel anticoagulants prior to recircuit? And the study that was published on the same topic is Venture AF, the protocol of which is briefly described in this slide. It was a randomized, open-label, active controlled study, the objective of which was to assess the safety of rivaroxaban versus VKA, both in an uninterrupted strategy in patients with AF undergoing catheter ablation. Paroxysmal, persistent, and long-standing persistent atrial fibrillation were allowed. Randomization was 1-to-1. The patient population, 248, was descriptive for the same reasons why we were discussing the limitations of COMPARE-HF. Both an early or a delayed ablation strategy were allowed to facilitate participations by different centers, with the time between randomization and procedure performance ranging between 1 to 7 days in the former and between 4 and 5 weeks in the latter strategy. After catheter ablation, during which intravenous heparin was administered according to the standard strategies by participating centers, patients were left on the assigned drug treatment and were followed for 30 plus minus more days, after which end of study was declared. The patient demographics were indicative of the typical patient population undergoing AF ablation, mean age about 60 years, 75% males, paroxysmal as the predominant type of underlying AF ablation type, congestive heart failure less than 10% of the population, hypertension most prevalent comorbidity but only 50% or less, prior stroke very limited population, CHATS 0.7, CHATS VASC 1.6, and most if not all patients undergoing prior antiarrhythmic therapy and one or more types of anticoagulation antiplatelets therapy. This slide shows the primary outcome event analysis. The primary endpoint was major bleeding event. Only one event out of 244 patients representing the safety population, accidentally in the VKA arm. In terms of thromboembolic events, 2 events, again, accidentally both in the VKA arm. One was an ischemic stroke and another was a vascular death. So in summary, why anticoagulation therapy in patients undergoing AF ablation? To limit the risk of periprocedural stroke and systemic and peripheral embolism. With which anticoagulation strategy? Uninterrupted VKA represents the most popular one at this point in time. We have briefly addressed the potential limitations of the sources that have generated this statement. Do novel or anticoagulants favorably compete with standard of care? Apparently so, but mostly observational study. Which studies were testing NOACs prior to recircuit? Venture AF for rivaroxaban, showing little risk and little differences versus VKA on an exploratory basis.
Exactly. And to your point, to your third question, right? Do NOACs favorably compete? We have to say until we had VentureAF and Recircuit, it was mainly observational. With these two, we have some descriptive but prospective studies that are addressing this, right? There's one question here that deals with the VentureAF way, with the way in which rivaroxaban was managed in VentureAF. So you said on continued rivaroxaban, when did patients actually take in their last dose of rivaroxaban in VentureAF, and what would you recommend to somebody out there that has a patient on rivaroxaban? How should they manage that prior to AF ablation and afterwards?
So uninterrupted means rivaroxaban was administered the day before the procedure and was administered the day of the procedure. When was left to the investigator's best judgment. We wanted them to be highly flexible. But the protocol encouraged the administration of the last dose of rivaroxaban prior to the procedure, the evening before of the procedure. And the next dose, 6 hours after the end of the procedure, provided no bleeding complications were described or observed in the context of the procedure.
Okay, excellent. So really continued anticoagulation. And another more generic question, I guess, and that also goes into what Stefan Hundler was saying in the beginning. So a patient with a CHA2DS2-VASc of 0 that is undergoing AF ablation, would you pre-treat that patient with anticoagulation prior to performing the AF ablation?
Well, what VentureAF suggests, and we will see the same for Recircuit after Stefan's presentation, is that using a protocol that administrates novel or anticoagulants 3 to 6 weeks before ablation provides the best protection for the patient at the time of the procedure. The incidence of events observed in this study is the low incidence of bleeding and thromboembolic events encourages the applicability of that protocol to our daily practice.
And importantly,
even in patients with low or CHADs and CHA2DS2-VAScs.
And importantly, even in those patients, we would use some form of imaging, mostly, I guess, TEE, in order to exclude a thrombus prior to performing the ablation procedure. Stefan, what's your take on that?
Well, I would echo this, and I would agree with that statement. At least in our institution, we are doing it in all of our patients, but I know that there are opposite opinions on this, and this is something which has to be discussed. I would not take the risk, even if the risk would be very small. That is my take on this.
Absolutely.
And I think the guideline documents and the consensus documents would encourage that as well.
Yeah, absolutely. So great. Thank you, Ricardo, for this beautiful overview. Then we hand back to Stefan Hundler for the Recircuit trial.
Sure. It's my pleasure to present the results of the Recircuit trial on behalf of the steering committee and, of course, all the investigators participating in that study. This slide shows basically the key information on the design and the conduct of the Recircuit trial, which was basically assessing the safety of uninterrupted treatment with dabigatran versus warfarin in patients undergoing AF ablation. As you can see, patients with either paroxysmal or persistent atrial fibrillation were eligible for the trial. 2/3 of patients were actually suffering from paroxysmal. The third was suffering from persistent atrial fibrillation. Now, if the patient agreed to the protocol and to participate in the study, he or she was randomized. And then there was a period of 4 to 8 weeks with anticoagulation. Patients were either receiving uninterrupted dabigatran at a dose of 150 milligram BID, so the so-called high dose of dabigatran, or they were treated with uninterrupted warfarin, again aiming, as Ricardo has already pointed out, at an INR of 2 to 3. The primary outcome measure of the Recircuit trial, which was not an efficacy trial, if you wish, because that would have taken thousands of patients to be randomized. The primary endpoint was ISTH-defined major bleeding events. And all of these bleeding events were adjudicated by a blinded evaluation committee. So the study basically has a so-called probe design, prospective, randomized,
Open label.
open label blinded evaluation trial. A total of 678 patients were actually enrolled in the trial and were ablated and formed the basis of this study. As you can see on the bottom of the slide, there was really uninterrupted continuous anticoagulation in both treatment arms. It is important perhaps to emphasize that the dabigatran was also given the morning of the ablation procedure. So all patients received the morning dose, and the dabigatran could be resumed after the procedure as early as 3 hours or the evening, latest the evening of the same day. During the procedure, patients were treated with unfractionated heparin, which was encouraged to be administered immediately after or before transeptal puncture. And we asked the investigators to adjust the ACT to a level of above 300 seconds, as it is recommended by the guidelines as well. This slide shows the patient disposition. As I already emphasized, 678 patients were randomized, so the groups comprised 339 patients both. This is, at this point in time, the largest prospective observational study in this field. And 317 and 318 patients could be actually evaluated after ablation. The other patients dropped out for various reasons, as you can see here. This slide shows the major outcome of the ReCircuit trial. You can see on the left-hand side the incidence of major bleeding events. Again, all were adjudicated by an evaluation committee. So in the dabigatran arm, a total of 5 patients had a major bleeding event, and that compared to a total of 22 patients in the Warfarin arm having such events. So this is representing an absolute risk reduction of 5.3%, or a relative risk reduction of 77%. Quite impressive risk reduction, I would call this. If we look at what constituted the major bleeding events, there are 2 event types which stand out. One is pericardial tamponade, as emphasized by Ricardo already. This is the most feared bleeding complication. Only 1 patient in the dabigatran group suffered from such an event compared to 6 patients treated with Warfarin having a pericardial tamponade. The second major contributor to the difference in bleeding events was groin hematoma. There was actually no groin hematoma in the dabigatran treated group, and there were 8 in the Warfarin group, and those 2 pericardial tamponade, groin hematoma constituted the major drivers of these events and the difference, of course. If you look, if you ask yourself the question, how many of these events required medical attention, immediate medical action, you can see that in the dabigatran group, 4 patients needed medical action compared to 21 in the Warfarin group. As a type of consistency test, we performed the second analysis, this time using Cox proportional hazard modeling. And you can see the accumulating events of major bleeding events in the Warfarin group and in the dabigatran group. As expected, the majority of these events occurred within the first 7 to 10 days. And you can see the rather dramatic difference of these particularly early major bleeding events if you compare the Warfarin group and the dabigatran group here. So very consistent results, no matter how you look at the data and how you analyze the data. This is, we asked ourselves the question, has the INR something to do with the likelihood of bleeding? Or is the ACT different in the Warfarin and the dabigatran group? As to the first question, you can see here that the average INR prior to ablation in patients having a major bleeding event was 2.4. And the average INR prior to ablation in those patients who did not have major bleeding events was 2.3, so no difference whatsoever. If you look at the ACT for the dabigatran group and for the warfarin group, again dividing patients by whether or not they had a major bleeding event, you can see that there was no statistical significant difference. Remember that this 374 seconds is based on data from 5 patients only, because only 5 patients had such an event. Patients without bleeding events had basically the same ACT during the procedure, irrespective of whether they had dabigatran or warfarin. So to look at it another way, is investigators were extremely adherent to the study protocol.
So that also answers one of the questions that our viewer Ivan had, if there's any difference in bleeding rates between an INR of 2 and 3. You're actually showing quite nicely that, at least taking it the other way around,
Exactly.
those with bleeding versus those without a bleeding had pretty much the same INR.
Yeah.
I guess it is prudent either way, right after, before and after the ablation, if the patient is on vitamin K antagonist, to check more frequently than usual for them to not get out of range.
Well, that was done that was encouraged in the Recircuit trial, and I believe in the Venture AF trial as well. And this is something you would do on a clinical routine basis, so to speak.
Yeah.
I would agree with that.
Excellent.
So this slide summarizes bleeding and ischemic events, just to indicate that there was no difference in terms of minor bleeding events between the two treatment regimens. There was only one thromboembolic event, so again, like in the Venture AF trial, very low rate of thromboembolic events in the Recircuit trial, which again speaks to the quality of the centers and the accuracy of the investigators. And if you combine this and build your composite endpoint of major bleeding and thrombotic events, you can see this difference, which was already evident if you look only at the bleeding events. This slide depicts all adverse events. If you take any adverse event, you can see that there was no significant difference between the two treatment groups, as one would expect. The major focus in this slide is to be given on the last 2 rows here. I have summarized those adverse events requiring hospitalization, and you can see that at least numerically there's a difference in favor of dabigatran, 7.7% versus 10% with warfarin. And similarly, if you're looking at adverse events which prolonged the need for hospitalization of a patient, there was a difference, 3.8% favoring dabigatran over 6.5% in the warfarin group. I think those are also interesting observations, nothing more, nothing less.
It's clearly going in the right direction.
In the right direction, absolutely. So I believe we can summarize from the Recircuit trial that compared with uninterrupted warfarin, truly uninterrupted dabigatran therapy at this dose was associated with a lower incidence of major bleeding events during and up to 2 months after AF ablation. There were no thromboembolic events observed in patients receiving uninterrupted dabigatran. There was only 1 TIA in the warfarin group. So in total, in summary, very, very low incidence of thromboembolic events, which on the other hand emphasizes the impossibility of performing a formal superiority or even non-inferiority trial with this endpoint. And perhaps one last thought would be that another potential advantage of periprocedural use of dabigatran is, of course, the fact that we have a specific reversal agent, idarucizumab, available to us. This is specifically antagonizing the dabigatran anticoagulation effect. Despite its availability during the conduct of Recircuit in many countries, we did not need it in a single patient, but it's a nice add-on and a nice thing to have.
Excellent. Absolutely. Well, thank you very much, Stefan Unloser. That was a very, very comprehensive and interesting presentation on the Recircuit data just recently published and presented. Congratulations also on the study, obviously. Before we go into our questions, and we do have quite a couple of very interesting and good questions that we'll be tackling, the one thing that really struck me with Recircuit was that it was somewhat, when we first took a look at the first observational data also that Ricardo was showing in the beginning, there were some data back in, I think it was 2012 or so, first observational data for the Bigatran that went into the other direction, where they actually saw more, both more ischemic and more bleeding events under partially uninterrupted, the Bigatran compared to vitamin K antagonists. Any thoughts on that?
Yes, of course, I have some thoughts on that. The most important thought is that the evidence stemming from a randomized controlled trial is clearly superior at the evidence of uncontrolled observational data. I mean, no matter where we look, in which field of cardiology, this comes true over and over again. Another point is that these early studies were conducted only a few years, 1 or 2 years after the introduction of dabigatran into clinical practice after approval following the RELY trial. And people were not as experienced as they were probably in 2016-17 when Recircuit was conducted in how to use dabigatran. And finally, the last point is, because it was observational data, everybody did what he or she thought would be the best way to tackle the problem. So there is no unified, dosing schedule or medication schedule. The way dabigatran was administered, the way Warfarin was administered, many of those studies still use bridging therapy in both treatment arms. So there are lots and lots and lots of drawbacks in these studies. And I believe that the Recircuit trial, which, by the way, is the largest of all of the dabigatran observational trials, is really, by virtue of the fact that it is a randomized controlled trial, the strongest evidence we have today.
It shows us again, right? Exactly that. And I think we're quite privileged in cardiology. We do have a lot of randomized controlled trials out there. And I think with those trials, with those positive results from Recircuit, also from VentureAF, it gives us the evidence base to really guide our clinical practice. But as you were saying, we should not forget to try and mimic that as good as possible, the protocols that were set up by the groups, to mimic that as close as possible in order to replicate those findings. And these observational studies, they are important. They are important for various questions, but they will never have the same level of evidence or create the same level of evidence than randomized trials. And fortunately, people saw this the same way and started the VentureAF and also the Recircuit trial and weren't discouraged at the time when these rather negative findings came out. Ricardo.
Stefan, one question I have for you. Weren't you surprised by the odd distribution of events such as pericardial tamponade and intracranial bleeding in the VKA arm of Recircuit? Not because they were more often observed than in the Bigatran, but because they were unusually prevalent as compared to what is expected in a similar population.
Well, again, of course, we asked ourselves the same question. Is that more than we see in other trials? And again, you have to admit that this is a controlled trial and patients were randomized at the same institutions. So I think what we observe is true. There is more bleeding with Warfarin than there is with dabigatran. And that is true also in the pivotal phase 3 trials in atrial fibrillation. No matter where you look, you find the same evidence. Of course, it's always difficult. A lot of the bleeding complications depends on the patient population. The sicker the patient population, the higher your bleeding rate in general, irrespective of how you treat your patient. And the patients in the Recircuit trial were at slightly higher risk, I'd say, than the patients in VentureAF. The mean Jets VAS score was 2.2. In Recircuit, it was 1.2, I believe, or 8 in VentureAF. So we can, if we look at the patient population, we will also see differences which help to explain. But again, the main point is patients were randomized at the same institution by the same investigators doing the same procedures in a very careful way.
And as you were saying in the probe design, the endpoints were adjudicated in a
Absolutely.
blinded fashion. So whoever adjudicated the endpoints did not know what arm these patients were randomized to.
Exactly.
So our viewer Claire from the UK here asks a question that likely we won't be able to answer, but it sets up a larger scale, and I'll follow up on her question. She asks, how many AF ablations are performed nowadays with warfarin now that the NOACs are so widely used? I think that's a tough question, Claire, but I think we can because we would likely have to have some registry data for that to answer that. But let me rephrase that question. Now with the positive results, first from VentureAF and now also from Recircuit in an even larger population, should we switch a patient that is currently under vitamin K antagonist to a NOAC prior to AF ablation? Or would you still do it under continued warfarin?
Well, I mean, the evidence is that at least from these two, I would call them medium-sized or smaller studies, the evidence is that there's advantage if you do it with either dabigatran or rivaroxaban. The first point is there will be two more studies, one using apixaban and one using edoxaban for the same setting, the same comparison against warfarin. So in about 1.5 years or so, we will have a complete portfolio, so to speak, on how the NOACs perform in the setting of atrial fibrillation ablation. That's my first point. My second point would be, as we have seen from these randomized trials, many of these patients have a low CHA2DS2-VASc score, right? 0 or 1. So they come to see you not being anticoagulated at all. And you discuss the option of catheter ablation, and if the patient says that's what I wanted to have, then you need to start anticoagulation. And nowadays, I would never ever start a patient on warfarin. I would ever start the patient on one of the NOACs.
Yeah, absolutely.
So in many cases, the problem is really not existing. Now, the key question perhaps is, there's this patient who has been on warfarin for 5 years and decides he wants to have an ablation procedure. Do you switch that patient? I would say I would discuss it on an individual basis with the patient. There's no data guiding us in that regard. And my inclination would be to switch him to one of the NOACs as well. But that's my take.
Ricardo, anything to
You
add
can
to that?
argue
What's your
against
view?
that.
Well, the picture has been beautifully represented by Stefan. I think most of the situations have been represented, and I would certainly support everything he said. The only exception being if a patient is on 5 years of VKA, very well handled, no complications, nothing at all, I would keep this patient under VKA just because we have no evidence that justifies a switch. There may be trouble with a switch. There may be individual idiosyncrasy with a new drug, whatever the category that we are using. And that patient would certainly wonder why we took this initiative if he developed a little complication, particularly for the limited amount of time period that we are considering. Another question would be, would catheter ablation be a good opportunity to switch the patient to a novel anticoagulant?
In general, yeah.
In general terms. Unfortunately, catheter ablation has implications on the future of AF burden of that patient, and there is still a pending question whether chronic anticoagulation following catheter ablation should be continued in this population or not. If you ask me the same situation for cardioversion, I would definitely state this is the right time for you to change and switch from a VKA to a NOAC.
So
But
just
with
again,
catheter ablation, this implication makes. The other situation I wanted to address, if the patient never had anticoagulation before and he has CHATS or CHATS-VASc 0, would we encourage the administration of a NOAC, I would follow your suggestion. If this is the first user, NOAC better than VKA, would we encourage the use of a NOAC for 8 weeks before ablation? This question has not been answered, but the data coming from Venture AF and ReCircuit encourage us to believe that this might be the case to best protect our patients from the risk of thromboembolic periprocedural events.
Thank you. I think that's an important aspect. The other thing that you mentioned, and I think to get everybody just briefly on the same page, we're talking about a low-risk patient, say about a CHA2DS2-VASc 0 patient. So we perform cardioversion in a patient like that. We would pre-treat that patient if we don't do a TEE. We would pre-treat that patient, pre-anticoagulate that patient, perform cardioversion usually for 3 weeks, perform cardioversion, anticoagulate for another 4 weeks, and then stop anticoagulation. In a CHA2DS2-VASc 0 patient, usually this is how we do it. Now, for AF ablation, how long first in a CHA2DS2-VASc 0, and then second, to follow up on what you were already touching on, in a CHA2DS2-VASc 4 patient, for example, how long do we anticoagulate after AF ablation? Maybe Ricardo, you want to start, and then we'll have Stefan's
First
opinion.
of all, there are no definitive answers for an entire population which is represented by these two categories. The typical CHA2DS2-VASc 0 and the typical CHA2DS2-VASc 4 have individual qualities that highlights our clinical perception and need adaptation. But let's take into account the extreme situation of the CHA2DS2-VASc 0. It is intuitive that in a patient who didn't have anticoagulation before ablation, undergoes ablation and has likely a much lower burden, if at all, of atrial fibrillation following catheter ablation, that this patient would require continuous anticoagulation after 4 to 8 weeks from the procedure or more. But the point is, what if, any kind of arrhythmia was inadvertently induced in this patient that would dramatically change the burden of the patient, or whether any comorbidity was identified during follow-up that was not present at that point in time. For the CHA2DS2-VASc 4 patient, we have a different situation here. And I would say that everybody in the medical population and in the patient population would love to come to a point where they say, okay, after 3 months post-ablation, you're entitled to discontinue your anticoagulation therapy because we could prove undisputably that there is no atrial fibrillation any longer. Clearly, everybody would love it, but unfortunately, we have to say that we miss the evidence that would corroborate such an intuitive choice from a clinical standpoint. And there are 2 reasons for that. Reason number 1 is there may be a burden of asymptomatic atrial arrhythmias that might increase the risk of the population. And second, that there is growing level of evidence that the risk of thromboembolic events does not necessarily and uniquely depend on the presence of atrial fibrillation. So even the patient who never had atrial fibrillation is becoming now the focus of attention of scientific authorities in search of charts or CHA2DS2-VASc categorization that might identify patients that would benefit from anticoagulation therapy despite the absence of atrial fibrillation.
Absolutely.
And particularly now, and this is my last sentence, that we have novel oral anticoagulants that are associated with such a lower bleeding risk exposure over time than the previous VKA.
Exactly. Very nice. Thank you, Ricardo. Stefan, anything to add to that?
A few thoughts perhaps to add on this. I think that if we are honest, we have to admit that we have a relatively high relapse rate of atrial fibrillation after ablation procedures. So at least 30 to 40% in the first year will relapse to atrial fibrillation, which is why in the complete absence of data from control trials, I would advise every patient with a CHA2-VASc of 2 or larger to continue lifelong on anticoagulation at the present time. We can discuss this in a CHA2-0 or CHA2-1 patient, as you alluded to, but certainly not if the patient has a CHA2-VASc of 2 and higher, given the background likelihood, so to speak, of relapsing into atrial fibrillation, which may be completely asymptomatic, and only by appropriate means you can detect it. That's my first thought. The second thought would be that while we are talking, several studies are looking into that problem, randomizing low CHA2-VASc patients into continuous versus stopping anticoagulation therapy. These data are desperately wanted.
Absolutely, and we're absolutely. I would love to tell my patients, look, I'm doing something prognostically for you. I'm reducing morbidity, I'm reducing mortality. At this point in time, we can't. We do have some observational data that point in the right direction, but like we were saying earlier, nothing like a randomized trial to really answer that important question. So to answer that question, because it came up several times in a patient with an indication for anticoagulation, also according to current guidelines, we will continue infinitely with anticoagulation according to CHA2-VASc score, even after successful ablation, due to the relapse and due to what Ricardo was alluding to, the possibility or the growing evidence that AF is also a marker of an increased risk of stroke in these individuals. So I think for the last 10 minutes of our webinar, because we do have a couple of questions left, I think we'll go into rapid fire mode. So we'll have one question and a quick and succinct answer. We'll start with you, Ricardo. Cryoablation or radiofrequency ablation? Any difference with respect to the management of anticoagulation?
Not that we are aware of. First of all, these two procedures appear to be similarly effective, which facilitates the selection in the first place. Once we have this information available, we have no evidence that any anticoagulation strategy can be preferred in one form of ablation versus the other.
Okay, very good. Second question, I will tackle that myself. What to do in patients with dual antiplatelet therapy after PCI and stents that need AF ablation? My answer would be wait until the time of DAPT is over, because hardly ever is AF ablation an emergency type of procedure. I would definitely push that back, try and do it, bridge it with some sort of medication until you can drop at least one of the antiplatelets and then go for AF ablation.
Absolutely, there's no place to do ablation on triple therapy or something like that.
Excellent, thank you very much. Now, next one for you, Stefan. This is also a tough one. What would you consider the most suitable anticoagulant for AF patients with chronic kidney disease that's undergoing an ablation procedure?
Well, it's basically the same considerations apply for all patients with atrial fibrillation. If you have severe kidney disease, I would think twice to do an AF ablation, to be honest with you. And of course, if you have a creatinine clearance which is really low, below 25 ml per min or something like that, then there's no place. Then you cannot use NOACs in that particular patient. Would you use VKAs? Well, you probably have to, but there are mixed observations, I'd say, in terms of complications. So a patient with severe kidney disease or renal replacement therapy, I would think twice about an AF ablation.
Can I add on this?
Absolutely.
Well, if you have a chronic kidney disease, we may have a very selected population that only has this disease, but generally this population has a high comorbidity. The first thing we as clinicians, even before then electrophysiologists, have to ask ourselves is, would an unlikely long-term resumption of sinus rhythm in this patient population significantly improve the symptoms perception? In other terms, how much does atrial fibrillation contribute to the reasons why the patients are coming to our attention?
Point, yeah.
If we were able to dissect out the role of atrial fibrillation in the context of the wide variability that other comorbidity are bringing into the clinical picture, and prove that the patient is suffering from atrial fibrillation per se, then all the considerations that Stefan made get authority. But before that, I think a substantial proportion of these patients would be eliminated.
Yes, that's a very, very good point indeed. I mean, chronic renal failure is really a conundrum that we're dealing with, that we have to deal with. Unfortunately, now we are embarking on the studies that are tackling these very difficult to treat patients. And that's aside from ablation. I mean, even the question how to anticoagulate these patients, it's not at all clear. I mean, Stefan Honosa published in the European Heart Journal 2012 the subgroup analysis of Aristotle, where it was nicely shown that although the rates go up as renal function goes down, that rate, especially for bleeding, goes up much more with vitamin K antagonists, right? Yep. Which is, as a result of which, it is now no longer a class 3 recommendation in the new guidelines. Yep. Even severe renal failure is no longer a class 3 recommendation. But as you were both saying, we just simply don't know what to do in these patients. And maybe the tipping point for anticoagulation in these patients, the further we go down with renal function, we will reach at one point an inflection point where there is no benefit of anticoagulation anymore. And we don't know.
And companies that are investing significant amount of energies in the introduction of these new drugs have priorities to prove the benefit of this drug before they embark into the risks associated with the unavoidable exposure to bleeding complications.
Absolutely, absolutely. Here's another one that goes a little bit into sort of a question 4B as the one that we tackled before. And I'll give the word first to you this time, Stefan. Now, it's again about a CHA2DS2-VASc patient. CHA2DS2-VASc 0 at the time of catheter ablation, successful ablation, asymptomatic. Now, 3 years later, has a CHA2DS2-VASc of 3. Is over 65 now, is hypertensive, and has developed diabetes. Do you anticoagulate that guy? Hasn't had symptomatic AF for the last 3 years since AF ablation.
Well, that's a tricky question, I must say.
I know. You can
it's
say
not
this
one for
to
the rapid fire session.
But it speaks a lot in favor of the audience. That
Absolutely. Good question, Mio. Good question.
You know, I mean, first of all, you have to look carefully whether or not the patient has asymptomatic atrial fibrillation. If you take the example of pacemaker patients, you'd be surprised how much asymptomatic atrial fibrillation you find in a 70-year-old with hypertension, as we have shown in the ASSERT trial. So I would really look hard before I recommend not to go on anticoagulation in that particular patient. So again, my inclination would be rather positive for anticoagulation than negative. But that's a tricky question.
What about secondary atrial fibrillation? So a patient that has a femur, a fracture of the leg, comes to the hospital, has AF diagnosed for the first time perioperatively after having the femur fixed. 80-year-old lady, hasn't had anything before. How do you go about this, aside from ablation?
Well, you're guided by the individual risk score assessment, as you would do with any other individual. So I would say above CHA2DS2 1 and above CHA2DS2-VASc 1 or 2, I would consider anticoagulation.
Yeah.
Now, this lady is 85, so she has already a CHA2DS2-VASc of 3.
Absolutely.
And that tells you that, again, if you are in doubt, rather go. I mean, this is the advantage of the non-vitamin K oral antagonist.
And the role of female sex has been revealed.
Well, I know, but even if you take it out.
Just for kidding.
Just
we know.
the age is, you know, and she has hypertension and diabetes.
Yeah, the role of women has always been revealed over the past history, so it doesn't really make too much of a difference.
I guess the point you're both making, and I think that's a good point, we should not go about this diagnosis of secondary atrial fibrillation too easily. Because secondary atrial fibrillation may just be AF, asymptomatic AF, that has just come to medical attention at that point in time when ultimately she was hooked up into a monitor or somebody performed an ECG. So, and then in many of those patients, it turns out it was paroxysmal atrial fibrillation to begin with that just now got symptomatic during in that context. Okay, excellent. I think we have made almost all of our questions. That's terrific. Wonderful. I hope you enjoyed this as much as I did. Just as we're approaching the end, I'd just like to briefly close the session by summarizing some of the key messages I think that we've learned for your daily clinical practice. Number one, I think what's been pretty clear, and it also came out during the discussion, when we talk about stroke prevention, atrial fibrillation, NOACs nowadays in 2017 are standard therapy. Definitely for the patients that are newly started. That's a class 1 recommendation in our European guidelines. We'll see what the Americans make out of this in their new version. Around atrial fibrillation, certainly if somebody's newly started around AF ablation, newly started on an anticoagulant, also here the consensus was pretty clear based on the evidence that we have to start that patient on a NOAC. Uninterrupted VKA treatment, if somebody is on VKA, uninterrupted VKA treatment is preferred over low molecular weight heparin bridging around AF ablation in these patients. And for NOACs, several studies are available today, especially the Venture AF and now the even bigger recircuit, that indicate that this strategy is also feasible in NOAC-treated patients, and that is specifically for dabigatran and also for rivaroxaban. Nevertheless, even with these very nice data available, various important practical and logistic aspects need to be followed to replicate these positive findings in daily clinical practice. And I think this is something important to keep in mind. We are in this luxurious situation that we have these data. We should try and follow those protocols that have been thought over, that have been implemented so nicely in order to replicate these beautiful findings. Which leads me to close this webinar. I'd like to thank Professor Hohenloser, Professor Cappato for joining us tonight. That was really a pleasure. I'd like to thank also Boehringer Ingelheim, who supported this webinar with an unrestricted educational grant. We certainly hope you enjoyed this time with us. And just as a reminder, you will be able to view again this webinar offline in a few days on the ESC website. With that, I'd like to thank you and wish you all a very good evening. Thank you.